who will be leading our next panel. And before I do that, I want to give a shout out to Lisa Hinton and the American Cancer Society.
Yeah.
Lisa came to me and really helped me one by one put this panel together. In fact, she picked all the panels. Thank you for that. Thank you for that. And this is a really, really vital conversation. So we're going to get going. Chelsea, do you want to use this mic too?
Yes.
People down there?
Here, I'll put it on this one.
All right. I really, really love the title of this because I'm able to do this all throughout. And it's not that I'm shushing everybody. It's really about the stigmas around cancer. Oh, yes. Nice and quiet. And that we don't like to talk about. We shush it. We put it under the rug. We run from it. We don't want to know. But today we have an amazing panel of women who are going to share information, expertise, testimonials, tips, advice, and good energy around a discussion that is quite sometimes hard for us to have. I want to do two quick things before I actually introduce them so that I don't interject in the full conversation. But just by a show of hands, how many of you have had some type of interaction with cancer, whether it's a family member, all hands up in the room? It's no surprise that cancer is very prevalent, particularly in communities of color, and so I applaud the Chicago Urban League for having this conversation today. The first thing I want to share, because I know we have people watching virtually, and I have a first cousin who is watching from Detroit, Michigan, and she rang the bell today. I'm so happy, Alma Jean. The second thing I want to share, see why I'm getting it out of the way? I had my own personal cancer scare in January of 2025. I felt a lump, wasn't sure what it was, and I will be transparent that I did not do my screenings every year like I should have. So when I went to the doctor to finally do it, they really didn't even have records for me because it had been a few years and they had no comparison. So I just went in and put on the whole armor, if you know what I mean. And when they scanned my body, they found that I was cancer-free. But I promised that if I got that, or whether I got that diagnosis or not, benign or malignant, that I was going to use my voice as a platform to inform and encourage others, women, men, everybody. Get your screening. It's better to know and be able to tackle it than to not know and it creeps up on you and we can't do anything about it. And so with that, I have gotten my personal testimonies out of the way, and I want this to be a very engaging panel, interactive, energetic. These women have taken time out of their busy schedules, and now it's time for you to meet them. I have a little bio on each one because they don't want to toot their own horns, but we need to know what their accomplishments are and just the amazing contributions they have given and continue to give to the community. To my immediate right, my new colleague, Dr. Paris Thomas. Let's give it up for Dr. Thomas. She is the Chief Executive Officer of Equal Hope, a nonprofit committed to eliminating health disparities and advancing equitable health care access. With a background in public health, research, and community advocacy, Dr. Thomas has led initiatives addressing systematic inequities in cancer outcomes, maternal health, and clinical trial diversity. I can't wait till we dive into that. Her career spanned work in federally qualified health centers, managed care, and quality improvement agencies, where she has developed strategies to improve care for underserved populations. She's passionate about reproductive justice and patient-centered solutions. She continues to drive policy and empower communities through education, advocacy, and access to life-saving screenings and treatments. Let's give it up one more time for Dr. Paris Thomas. And to her right is none other than Dr. Yvonne C. Collins. Dr. Collins is a gynecologic oncologist and current chief medical officer of county care within Cook County Health Hospital Systems. She is board certified in obstetrics, gynecology, and gynecologic oncology. Dr. Collins has devoted her career to educating underserved women on the importance of routine health maintenance, including pap smear tests. Her interests include community outreach and education on the causes, prevention, screening, and early detection of cervical cancer, which is preventable. I repeat, cervical cancer is preventable. She also has an interest in empowering women through education, eliminating barriers to care, and increasing access. She has worked with community organizations, area churches, beauty salons, task force, and the American Cancer Society on developing ways to decrease racial disparities related to cervical cancer diagnosis, treatments, and mortality. A round of applause for Dr. Yvonne C. Collins. And last but certainly not least, we have in our midst is Dr. No, it's just the energy over here with this doctor. But definitely credentialed up, Benita Fluker. All right. And she is a dedicated oncology physician assistant at John H. Stroger Jr. Hospital of Cook County, where she has served for over 2 decades. A passionate advocate, yes, 20+ years. A passionate advocate for cancer awareness and prevention, she provides compassionate, patient-centered care, ensuring individuals receive life-saving screenings, education, and treatment guidance. As a cervical cancer survivor, she uses her personal journey to empower others, particularly in underserved communities, to take charge of their health. Through mentorship, advocacy, and outreach, she continues to break barriers in healthcare, fostering conversations on early detection and equitable access to health care. Let's give it up for Benita Fluker. Wow, what a group of powerful women we have on this panel, and I'm so excited to get started with this conversation. We have questions prepared, but how many of you know when the conversation gets good, we go off script, right? So I'm going to start with what they asked me to ask you, and this is for all of you who have microphones. Doctor, you and I can share, and the two of you can share. Sharing is caring, and I will start with this question. Why do you think people are still hesitant in 2025 to talk about the fact that they or a loved one has cancer? And we'll start with you, Dr. Collins. We just ask that you all speak directly into the mic, and then your voices will project to the back of the room.
Good afternoon. Thank you guys very much for the invitation. First of all, thank you to all of you who decided to join us. I talk about this all day long, and I still find it really hard in 2025 that we still have to talk about cancer being taboo. Very commonly, we don't talk about it in our family, so we don't know that it can be passed on. Very commonly, people are fearful of talking about it. They're fearful even that it's contagious. It's fearful that people will look at them, that they haven't been vigilant about their care. Sometimes they are isolated and scared and just not sure what to do. As a surgeon, I also very commonly hear when surgery is needed, I don't want surgery because that causes the cancer to spread. So we have to deal with a lot of myths also around cancer. But because we don't talk about it, people don't find support. They end up being very isolated, and then that isolation leads to really compromise and impairment in your mental health. And then that just becomes a vicious circle. So I want everybody to understand here today that you do have the power. And you should talk about it, because there are people who have walked in your footsteps who might be able to help you.
Cancer. The topic we don't want to talk about, but for those who are in the marketplace, please continue to enjoy yourselves. We just ask that you use your conversation levels to be a little bit lower so we can all get this great information. Thank you so much.
First of all, I'd like to just thank God. I'd like to thank God for the opportunity to be before you alive. Secondly, my mom, who's the battery in my backpack. Thirdly, Dr. Collins, who I've had the opportunity to witness such a talented clinician, surgeon, impeccable surgeon, no post-op complications, who has mentored me and stays in my brain every time I encounter a patient. So with that, she facilitates my efforts every day to make sure when that patient walks out of that room with me, they are empowered with agency and education. So to your point, to answer the question, why is that this is something that we don't talk about? In my personal and cultural belief, I believe that we are silenced because, as a community of color, because of lack of resources available to us and gives us access to the education we need. Silence in the vein of our emotions. Once we get that diagnosis, we have to take that pregnant pause and digest how we're going to navigate through this journey. So once we do that, we don't want to impose that emotional stress on our families. And so we feel, especially as Black women, I can do this by myself. I cannot tell you how many patients come in there, please don't tell my family, please don't tell my spouse, please don't tell my partner, and then judgment. We feel that we are, providers make patients with cancer sometimes feel that they're responsible for the cancer, whether it's dietary, whether it's intimate partner relationship, as in cervical cancer with HPV virus. All it takes is one time. All it takes is one time. And then the guilt that is imposed upon us for the presumption that we let this happen to ourselves. So that's why I think it's a don't talk about it moment.
Yes.
And they gave you all the reasons from a community standpoint, because we're a grassroots organization. These are all the things that we see all the time. We see many women who are grandmothers taking care of their grandkids, and they're like, I don't want them to know because they have to be the strong one from everybody else, or they don't want that judgment. There's also the medical mistrust piece. We find that often many people are still even processing what is happening to them, right? Like, I don't have cancer, I'm going to continue on, I'll be fine. And so we have to really come to the realization of putting ourselves first, especially as Black women, because we are the ones that are more likely to die from all of the conditions that we're going to talk about here today.
Thank you so much. Very, very insightful. Those fears are going to stop today. This is what this panel discussion is about, encouraging us to talk about it and be very open. But it's one thing to talk, but we have the numbers to match. Right here on the screen, as you can see, we have some slides, and we're going to talk about it through question number 2. What are the most common cancers we see in women, and are there types of cancers that are more common in Black women? And I just ask that you talk directly into the mic. That's what makes your voice travel.
I think I'm going to try it like this. There you go. I'm so glad you guys can see the slide. When we look at cancer incidence, that is new cases. Number 1, lung cancer. We now know women smoke as much as men. That has changed over the course of years. When we look at number 2, it depends on sex. So breast cancer for women, female breast cancer, and then prostate cancer in men. And then number 3, colorectal cancer. So when we talk about those cancers, all of those cancers, and we're going to come back to it, have screening tests. When we talk about death, same cancers, just sort of reverse order. Okay? So when we look at mortality, for these cancers. And you can see that at the bottom, lung cancer kills a lot of people. And we're going to talk about ways that you can prevent that. But what I want to talk about also, because we're talking about populations of color, black women, although we are screened more than white women, we continue to present with more advanced breast cancers, more higher stages of breast cancer, and we die more frequently from breast cancer. And very similarly for men with prostate cancer.
Can I say why?
Yeah. So the million-dollar question. So that's why research becomes so important. So before we thought maybe it's just socioeconomics, maybe it's just because you're not being screened, but now we know there are some cultural, some biases that providers have. So sometimes folks are not treated the same way. But even if we look at women that are treated exactly the same, there are differences in the response rates for black women. And so as we're looking at that, we're getting to the genetic makeup of the tumor, which is very different in black women. And when we talk about it at the end, that's why research is so very important. Very similarly for prostate cancer, black men are 2 times more likely to die from prostate cancer. And so when we're looking at all of the possibilities of things we can do, we have to remember that screening, which we're going to come back to momentarily, plays a significant role. But we as blacks are disproportionately impacted by just about every cancer. I could probably say every disease.
Is there another slide?
No, that's it for that question.
All right, Doc.
And just to add to that, black women in Chicago actually at some point had the highest death rate in the nation. Around the time frame of 2007, we were 62% more likely to die from breast cancer when the nation was only at 42% for that rate. We were 20% higher than the national average. So it's not just the breast cancers, but there's additional cancers. So right now in research, we're seeing more black women presenting with deaths in uterine cancers and ovarian cancers. And we know that we have to approach this and intervene quickly. Also, women under the age of 40, breast cancer, when we're going to get to screening, but we're finding that women under the age of 40 are presenting with more aggressive breast cancers, and they are not responding to therapy the same way as women over the age of 50. And so that is another conversation to be had as to what is happening. And so we as an organization really look through a structural lens, along with everything that Dr. Collins said. Something that does contribute to Chicago's disparity specifically is the quality of care. So where you go get your care here in Chicago does matter. We have amazing facilities, we have amazing safety net hospitals, but we do know that some of our hospitals that happen to be safety net hospitals struggle a little bit more in retaining talent, keeping their doors open, having stable staff. Those things play into their ability to provide high quality care. So specifically when you get a mammogram, there's a mammography technologist that has specific training and understands how to put your breast in that machine, being able to understand the positioning, the pressure, all of those things. Sometimes the techs in certain facilities don't have that training. And we found that there was and I don't want to give a percentage, there was a large amount of women here in Chicago whose cancers were actually missed. And that is why that death rate went up to 62%. The way we're screened and the access to care is very important. Then also when we're going through treatment, ensuring that we have a comprehensive approach to our cancer. So we know Cook County does an amazing job with this. A lot of our other academic medical centers do an amazing job to give you a comprehensive approach versus a team approach so that everyone, and it's not contracted out providers who are kind of just running up the bill, right? These are people who really want you to have the best outcomes. They're offering you clinical trials. They're offering you the best care. So that is another piece that adds to the disparities that we see in these cancers.
I just wanted to piggyback off of the last 2 responses. I'm not quite sure if you guys remember a case that was an unfortunate case with Jessica Petway. She's an African-American influencer who had vaginal bleeding, kept going to the emergency room three times. Was dismissed as fibroids, right? This is a woman that has thousands of followers. She knew something was wrong. She was in her 30s. But as it was presented today, it's who takes care of you? Who takes that extra time to say we need to get an ultrasound or a CT scan? Something that will lead us to the diagnosis. This woman went to the emergency room for almost a year. And then when she came to the ED with vaginal bleeding, it was a woman of color who looked in with the speculum and saw that she had like a fungating bleeding mass of the cervix. By the time they did the diagnostic workup, which would be a CT scan of the chest, abdomen, and pelvis, she was a stage 4. And 4 months after that, Ms. Petway died. So it's who and where. I will tell you today, all of you guys are the best professors for us. You're the best teachers for us. If you don't like the treatment that you're getting, go somewhere else. Your humanity is invaluable.
Can we just applaud right now the information that is being shared? So critical, things that, again, we don't want to talk about. But we're talking about it today. We're going to talk about screenings now. And I will share that there is a school of thought that there's more than one type of, specifically with breast cancer, testing around 3D and imaging. Before we go into the general question for all of you about can we screen for these cancers, can one or all of you speak to the recommended types of screenings we should get specifically for breast cancer? Because I understand there are some that reveal more and that we can delve a little deeper, or what the new research says, or what the availability.
Yeah, so a mammogram is your standard screening for you to get access to understand what is happening. I will say when it comes to family history, genetic makeup, such as the density of your breast, I'm sure many of you who've had mammogram have heard that word. There's a 4-category type of density. There's other machines that come into play. You may need an ultrasound. You may need an MRI. These are additional screens that you should be offered to be able to actually pinpoint and see what is happening inside of your breast. This is specifically important for us as women of color because a lot of us do happen to have dense breasts. And specifically in this space, we see that a lot of times if the facility is not referring you to those additional screenings, that cancer can go on to be missed. Because sometimes when you have dense breasts, it looks like a cloud. I don't know if you have a picture of imaging, so this is going to be hard to describe. But when you look through a mammogram, you can literally see like a little dot. But if you have dense breasts, it looks like a cloud. So try to find that dot in a cloud. It's almost very difficult where the additional screenings come into play.
I'm glad that you cleared that up. And again, this conversation is about all cancers, but I just wanted to bring that to light, seeing that you quoted the stat about us it being more aggressive, us not responding to treatment in the 30s, etc. And so now we're talking about overall screening for cancers. I mean, I really wish in a perfect world you could lie in the tunnel and they just screen you and scan you for everything and say, okay, this is it, but we see this. But I know that's not the case. So can docs and professionals please level set for us when it comes to screenings? I know colorectal is definitely going up the charts. There are ways that we can do home screenings and mail things in, and then there are other ways that can get a little bit more in depth. Please speak to that, doctor.
Well, if you lived in Florida, you could get in the scanner and find out what kind of cancer you have if you want to pay out of pocket.
Okay.
So it does exist.
Okay.
So breast cancer we talked about, I want you just really to be clear that when we talk about screening, we're talking about doing tests on you before you have any symptoms. So if you have symptoms, it's no longer screening. That's the first point I want to separate. Also, when we talk about screening, we always talk about general screening because there are diseases, genetic abnormalities that make you at higher risk for cancers, and then your screening may be different. I do that PSA just because I want everybody to take it with a nugget that your case may be different. So we talk about just really standard screening. We talked about breast cancer screening. So lung cancer, again, we talked about lung cancer as a deadly disease. We know that there is a screening for lung cancer. Only 16% of folks nationally have been screened for lung cancer. That's abysmal because we have a test that does a fantastic job. If you are a heavy smoker, that is a half a pack to a pack per day, for the last 15 years, and you are 50 to 80, you should be asking your provider, I need a screening test for lung cancer. It works. We know it picks up early disease. That's the whole point of screening. When we talk about colorectal screening, everybody knows a colonoscopy very commonly. You get you're tortured for 24 hours prior, and then you get your screening test. We know that test is fantastic at picking up abnormalities. it's good for 10 years. But for people who might not want to do that, and there are some, and we want to make sure that we can still screen, there is a smaller test that we call a sigmoidoscopy. If you think about your colon like the frame of a picture, that's your colon. The sigmoidoscopy just is the lower portion of that picture, that you look at the lower portion of the colon, in addition to a fecal test. You can do that every 5 years. That's effective for screening. Or you can do just that fecal test every year. And there are different kinds of tests. And that's if you don't have any risk of cancer, that is colon cancer, in your family. You don't have any risk of inflammatory diseases like Crohn's or inflammatory bowel disease. Because when you have those things, it all changes. It's different kinds of screening. Cervical cancer screening. Cervical cancer screening is really secondary. What we really should be doing is recommending that everybody from age 9, both boys and girls, have HPV vaccination. I want to say that again, because the Black community, I think, does not vaccinate well, but especially for a cancer that we know is related to a virus, and we have a vaccine against that virus. So you should be getting vaccinated. The pap smear is to pick up any abnormalities that you may have, and you should again have that. Again, different scenarios, but on average, that combination every 5 years.
Age range? What's the age range?
Generally starting at about 25, general population, again, we're talking very general, 25, pap smear, HPV testing, but vaccine is what the real preventative measure is when we talk about cervical cancer. Those are the ways we screen for very general cancers. And I'll stop there.
Thank you. Do you all want to add? You can add on because we have some great questions we want to get to. Please.
I just want to piggyback off of Dr. Collins. Not only do I do my primary clinic is gynecological oncology, but now I've been assigned to what's called the dysplasia clinic, which piggybacks off of getting your the significance of getting your pap smear. If that pap smear comes back abnormal as precancer cells, and you get a notification like you need to come to the dysplasia clinic, otherwise known as the colposcopy clinic, where we do biopsies, it's vital that you come to that clinic, because that's going to delineate for us whether this is still a precancer or it's going into a cancer. And I cannot tell you how many cancers I've found since I've been tasked to do this clinic. So now I'm the conduit for the people that are at pre-cancer, and that goes into the cancer. So we don't let anyone fall through that has an early stage cancer that could be operated on.
Just one more thing.
Please, Doc.
The other thing I want to remind folks, very commonly I hear, well, the doctor didn't call me, so everything must be fine. Don't assume that. I have stacks and stacks and stacks and stacks of things on my desk and in my inbox that perhaps I may have missed or that I didn't go through. You always, if someone doesn't call you to give you your results, you call them and hound them and get your results until you know that everything is normal. Don't make that assumption. We've had many people assume and then it be cancer.
And just adding to that, actually knowing the law is important here. So for mammograms and cervical cancers, the doctors are actually also supposed to mail out your results. It's supposed to be legible. So if you've not ever got a mailed out result of any of those things, they are not following the law. Also, when you have dense breasts, there is a letter that we have crafted. The state of Illinois has to use that says this is what you have as far as density, and this is what it means, and these are the guided screenings we would like you to follow so that we can see what happens next. So if you've never gotten a letter, your provider most likely is not following the law, because these are actually legislative things that we put in place.
And you may not have got a letter if you had a portal. Oh, so, yeah, it's in the portal. So I just want to
Yes.
I never got a letter.
I got a phone call, a letter, and notification in my portal. So now we have a packed room of those who are engaged, men, women, listening about these screenings. And so I want to pose the question to the entire panel about healthy habits that we can embrace starting today if we haven't been already, that could be preventive measures for cancer.
So we know that there are factors, we can go to the next slide, that make a difference in terms of not only you getting cancer, but your response to treatment. Number one is obesity. This is the slide. If you look at this slide, the goal is you want to be in the green, some portion of green. So who's that? Colorado and DC. Everybody else is fat. So when we think about it, obesity is the cause. We know that obesity is related to two things: what we eat and what we don't do in terms of exercise. How much exercise should we get in a week?
At least.
At least 150. Actually, the guidelines now say 150 to 300 minutes per week. That's 42 minutes a day if you want to do something every day. 42 minutes. And you can break that up. You can do 10 minutes in the morning, 10 minutes, so you don't have to do it all at one time. Nutrition. So what you eat, you want to really remember that what goes in, you want to do enough working out to compensate for what went in for your output. Smoking, I'm not going to have anybody raise their hands, but smoking, we know causes cancer. Not only does it cause lung cancer, it causes oral cancers, it perpetuates cervical cancer, and so stop smoking if you smoke. The other thing we know is alcohol. Alcohol. Anything more than 1 drink a day for women, 2 drinks for men, you probably should get some counseling. No, just joking. The research shows no more than 1 to 2 drinks depending upon sex. Anything more than that contributes to cancer. So oral cancers, esophageal cancers, liver cancers. So those are all things that we can do to really prevent cancer. We also know that if you're obese, you're less likely for some cancers to respond to your chemotherapy. Sometimes we can't give you enough chemotherapy because your weight is so high, the chemotherapy will become too toxic if we gave you the doses based on your weight. So weight, exercise, nutrition, alcohol, smoking. If you can do anything for yourselves, take one of those, work on them for the next 6 weeks, because 30 to 45 days becomes a routine. Yes. So take one of those and start working on them.
In addition to the smoking, because I think a lot of people dismiss this as a thing, vaping. So if you do vaping, which is a new thing that we're really trying to see in research, it will also lead to these things. So when we say smoking, it's covering the gambit. So just don't think it's cigarettes. It's also marijuana and also is vaping. So those things that are included. And then also stress. One of the biggest things that play a role in how we respond and if we present with a disease like cancer has to be the stress that we're enduring. So I encourage a lot of people, if you can, find a mental health therapist. Make sure you're taking care of yourself. I know we as women prioritize our families and everyone else. We have to prioritize our health and get those screenings so that we can prevent disease. And so adjacent to all of that, those things.
When you talked about the exercise piece, I just wanted to add a tip to it when you say you can just get it in. A lot of times exercising can be folded into some things that you're doing. You may be ironing your clothes and doing squats at the same time. You may be washing dishes and doing a little leg lift or taking a walk at lunchtime, and those types of things count as movement as well. This next question is specifically for our survivor. I just love that word, survivor, a survivor of cervical cancer. And this is for you. We're just asking you to please tell us about your experience and talk about the importance of advocating for yourself. What was it that made you, I know you're in the field, so that kind of gave you a leg up on what to look for, but still, what was it that happened that triggered you to say, I probably need to get this checked out? And please bring that mic all the way up because we are all
in full disclosure, I had triple. I had cervical, uterine, and colorectal cancer. Ooh. And so I was diagnosed. I was diagnosed in 2017, and with the cervical endometrial cancer. But I was having colorectal issues because I had a history of ulcerative colitis and Crohn's disease, which over time, there's a genetic component, which over time of your life does lead to colorectal cancer. So my colorectal surgeon was patching me up with multiple surgeries every 6 months, and so the cervical and the uterine cancer got delayed. And so I was like, I can't live like this anymore. I went from a healthy like 125 down to like, when I went into rehab, I was 80 pounds. And so I had to advocate for myself in 2018 to have this really comprehensive, complicated, extensive surgery where they take everything out in block that Dr. Collins does with cancers such as mine. The response I got from my doctors were like, no, we don't want to do this yet. So I kept going down until I had to go to my collaborative physician and say, hey, listen, I need your help to organize where I can have this surgery done or else I'm going to die. And so I was fortunate enough to have 3 qualified, who started off first? I think gynecology started off first, then colorectal came in and created my ileostomy, and then because I was so tiny, I had to have what's called a vertical rectus abdominal muscle taken out from my right side to close up my rectum because they took my rectum. Had I not been in the profession that I was in, and had I not had the knowledge that I have, I would have died. I had to advocate for myself, and throughout this whole course, I never tell people what I do, because when I step into your facility, I want to see how you're going to treat me. Because if you're going to treat me this way, then how are you going to treat me on the operating room table? Right? So we have to be very careful who we put our bodies into the hands of other people. Because if they see you as an other, to quote Kendrick Lamar, they're not like us, that should be your signal that you need to go somewhere else, that's someone who's going to invest in your cancer care. So I had this surgery. It was 12 hours. Because of subsequent complications, I was going back to surgery every Tuesday and Thursdays to get washed out. My wounds open. So it was a complicated process. I hit a brick wall. I was stuck in the hospital for 4 months. I reached out for psychological help. I called all of my surgeons. I said, all this fantastical surgery that you're doing on me is not going to work because my pain is not being controlled and I'm hitting a brick wall and I'm going to die. And so I got psych in and I got psych in and I got someone in to control my pain. I want to advocate that if you go through this process and you're just not feeling right, ask for psych help. I need someone to help me go through this process. Because if the mind is not right, the body will fail. It will fail. And so that's how I got through my recovery process. Going through PT, OT, I forgot how to walk, and we take things for granted. I remember one of our doctor colleagues came to see me, and I had to they took a box, and they put it on the floor, and they said, act like you're going to get into the bathtub. I couldn't do it. My mind had disassociated. It was so sick. And the thing about cancer, you can't feel it, you can't touch it, but it slowly destroys you. So I take that experience that I had, and if my patients are tearing up at the diagnosis, I'm going to say, we're going to get you to onco-psych. We're going to have a qualified psychologist see you. Go home and talk this. If a surgeon, not Dr. Collins, if a surgeon is trying to rush you into this surgery, pull the reins in and say, I'd like to talk to my family about this before I make this critical decision, right? So for me, it was different because I started to decline and I needed to rebuild myself. I needed to go from 65 pounds before they would do surgery. I had to be 114 pounds, 115 pounds. So do the necessary things you got to do if you want to live. At the same time, be careful about who you trust your humanity to. That's earned. They have to earn that.
We're all hanging on to your every word. I forgot I was the moderator. I'm back. I am back. Before we take take questions from the audience, I want to talk about the importance of clinical trials. We are so afraid to be a part of research, but we know that research is critical in order for us to find cures for these various cancers and to be able to determine how things impact different populations. So I would ask, as we close out this conversation and move to the audience, if each of you would weigh in on your thoughts around clinical trials, the importance of us being a part of it so that the data reflects our population.
So absolutely. First, I want to say our mistrust in the healthcare system is warranted. So I tell people that it's perfect. We're never going to dismiss your mistrust in this system because it has happened, right? But healthcare and research itself has done a lot of things to clean that up. And we do have to participate and be a part of these research and clinical trials because they're developing medications without us participating. So imagine, and I use my mother for example, when she went through breast cancer, they had developed a breast cancer cold cap that was supposed to prevent your hair from being lost. They did not test this in black women. This was something you would have to pay out of pocket for. They had only tested it in white women. So I was like, my mother is not going to do that because you didn't test it in her type of hair, right? So that's not going to help her. And we're going to be in debt for paying for this thing that you don't even know is going to work on. We have to be a part of this because they're going to keep developing things, and we want things that are going to help us live longer, but we have to participate. And right now we just aren't. And so we really have to build up that confidence in the healthcare system. There's amazing physicians like Dr. C and Benita, who's a PA, are doing this amazing work. And as she said, if you don't like where you're getting care, go somewhere else. Because we need to be a part of this conversation so that when they develop medications and they develop new technologies, we're a part of that. We can't stay in the background because they'll continue to develop new things and we just will not know what will happen to this.
We'll go right down the road.
So think about it. Clinical trials prevent you from getting polio. Clinical trials can prevent you from getting HIV, anybody, if you take preventative measures. Clinical trials have moved us from doing really aggressive surgeries for vulvar cancer to doing really pointed surgeries. Our clinical trials have allowed us to see that there are now medications for dementia. Clinical trials have allowed us to say black women are at increased risk of genetic abnormalities for any array of things, and now we can treat them better and differently and more personalized. That's what clinical trials do for us. Mind you, like Paris said, mistrust, absolutely. I tell providers all the time, I've never not gotten anybody in a clinical trial that I wanted because I treat everybody when I'm having the conversation like I'm talking to my mama, who's usually here, but is not today. And so I think you have to be patient. What we know from all of the literature is only less than 10% of blacks overall go into clinical trials. So if you think about if you take any kind of medication, if you use any kind of device, if you've had any kind of surgery, 90% chance it has not been studied on you. And now we wonder, like for high blood pressure, when we're giving medications to the black population, why it just doesn't work. Because it's different mechanisms based on some genetic abnormalities and makeup that we know that's making the difference. And so I tell you, clinical trials are really important. And I encourage you to do that. There are many, can you go to the next slide? There are many clinical, many clinical trials that are looking at how we respond as blacks to research. One is on the screen now. That's sponsored by the American Cancer Society. That is the voices of black women. Benita put it very nicely. We have many scenarios where black women have said, this is wrong, I don't feel right, I am sick, I am bleeding, I am dehydrated, I am getting ready to die, and no one listens to them. It's not poor women, it is Serena Williams, it is colonels in the military, it is physicians. And so we know it's not based on poverty, it's not based on socioeconomic status, it is based on the color of my skin. And so if we have to move past that, there are research studies trying to get our opinions. How do you want to be talked to? What's important to you? How does your environment affect what you do and how you respond? And so that's one trial. There's another trial that's looking at really the importance of all of us being a part of research. And so it's the All of Us campaign. There are some cards on chairs. But what we also know is that your environment also plays a role in how you get disease and how you respond to disease. And if we don't study populations equally, we'll never be able to treat patients equitably and effectively to eliminate healthcare disparities.
I really don't have much to add, but to just simply encourage you guys to get involved in clinical trials. I also just want to emphasize to you, there have been studies showing that we do better when we're treated and taken care of that people who look like us. So I just want to leave you with this. Like, if you're seeing a non-melanated person who's discounting your complaints, you can ask for someone. That is your right. I don't care if you're on Medicaid or if you have county care, that is your right. And if you involve yourself in a clinical trial, or if they're offering you some type of new therapy, ask how many black women or people of color are enrolled in this clinical trial. Because the only way that we're going to get to being cured, or having a cure, is if in masses. The numbers speak for themselves.
And so, yes, if everyone can pull out their phone for me, if you could please just take a shot of this QR code and sign up. This is really important. It's a longitudinal study, as Dr. C said, around this. When we talk about things about racial bias, implicit bias, things you experience in everyday life, this longitudinal study will look at black women, and they're looking to recruit over 100,000 black women to be a part of this. I am a participant. I even signed up as someone who does this every day. This is important to me. So please do this so that we can get down to some of those additional causes and we can understand why black women are dying at greater rates.
Can we get a round of applause for our panelists? I want to keep my promise to take a couple of questions as we move around the room. If there are any questions, if you want to tell them to me, you don't want to be on camera and I can repeat them. I will say, without naming names, I'm going to look in the ceiling, but I see one of my sisters from my hometown of Gary, Indiana. She is a breast cancer survivor, so let's clap for her. You'll say it out. I knew you would, Miss White. I'm just glad to see that. I see you nodding your head in agreement because you've been through it, and it's different for those of us who are just listening versus those who have actually gotten the call, gotten the diagnosis, cried the tears, wondering what was going to happen, but we see you here with us today. Are there any questions? I know we're getting to the closing point of our whole event, but I would be remiss if we didn't hear from our audience.
Good evening, everyone, and thank you, everybody, for participating today, and especially for your story and how candid it was. Thank you for being so brutally honest with all of us with your experience. I just wanted to, I didn't have a question per se, but I just wanted to share that, like they were saying, advocate for yourself and read everything that you get from your doctors. Because when I got diagnosed, it was a 1 centimeter lump in my breast, but the report came back and said it was 10 centimeters. And if anybody in here has had a baby,
Wow.
you have to dilate 10 centimeters to give birth. And you're the clinicians. Those reports are used to determine what kind of treatment you're going to get. So they had to amend my report. And luckily I'm an engineer. So if we don't pay attention to calculations, we can kill people with bridges and elevators, all that stuff. So not only did they miss the 1.0 and it said 10, it was supposed to say millimeter.
Thank you.
And I think it said centimeter. It was a mess. So I had to leave my home state to get treatment. So don't just trust the doctor. They're practicing on us. They practice medicine and they're practicing on us. Thank you for all that you do. We, honestly, thank you for advocating for us. But you're human. You're human. Know that your doctors are human and advocate for yourself like they said. So I had 2 mistakes on my diagnosis from my doctor. So I just wanted to say, just pay attention and read everything as it pertains to your diagnosis. Thank you.
And ask lots of questions.
Ask lots of questions.
We have another.
Thank you for this panel. I didn't hear everything that was said, but I have a very concerning question. I am extremely, exposed to secondhand smoke. It is so bad that I can taste it in my mouth. My hair, my clothes, everything. So and I did bring it up to my doctor, and she said, "Oh, you should be fine." But I have to spend about at least 3 hours, 3 to 4 days a week in this space. Should I be getting screened?
You probably should have some discussions, absolutely. We know that the secondhand smoke is probably worse than the smoker. There are many people who've been diagnosed and died from lung cancer solely from secondhand smoke. So absolutely, you should definitely have a different conversation.
So you say have a conversation. What does that mean?
So if your primary care doctor is not taking you seriously in terms of looking at you being screened, you should probably see somebody else. And we can talk offline about getting you in, and you can and what you can do also, and I can talk to you offline, is you can go to the American Lung Association website. They list all of the sites that do lung cancer screening, and you can call yourself.
Okay.
Yeah.
So we are at our time. I want to once more give these women, these mighty women, a round of applause. And I want to thank you for Chicago Urban League on behalf of our president and CEO, Karen Freeman Wilson, for this opportunity. Shameless plug for the Chicago Urban League. If you want to know more about our programs, and I'm sure you'll wrap up comment, please go to shyul.org. We have something going on just about every day. Subscribe to our newsletter, go to our website. Our social media is robust with information, not just from a health standpoint, employment, leadership, education, youth and family services. And so as a PR person, I'm always disheartened when somebody says, the Urban League, what do you do? And I'm like, no, we do so much. So this is just another mighty example of how we come together on behalf of the communities that we serve. I will now turn it over to my colleague and friend, our Chief Operating Officer, Calvin Cole.
Thank you, Chelsea. Let's give it up for Chelsea. Great moderator. And our panelists, so we have some gifts for you. Thank you. We appreciate so much what you shared. And I'm going to try to match the little thank you cards up with the bags. Okay. What you do with your phone? Is this whatever camera?
I'm good now, thank you.
Thank you.
Get over there and get your bag.
I said I was going to try.
You do?
All right. And Chelsea, even though you work with us all the time, I have something for you too.
Well, thank you, thank you.
All right. So again, this concludes our program, but we are still. I have to give away all of these gifts. So if you don't have your raffle ticket, get one now. We're gonna just go bang, bang, bang. Either they're here or they're not, and we're gonna keep it moving. Okay? You had a question, or you need a raffle?